Let's discuss this case. This patient is 19-year-old Elena. As a teenager, Elena began to notice a slowly progressive clumsiness in her lower extremities. Her ankles began to turn inward, gradually developing into a distinct equinovarus deformity of the feet. Along with this deformity, she experienced a moderate limb weakness that began to cause mild daily disability, especially when climbing stairs or walking long distances. When Elena finally sought evaluation from a neurologist, the clinical examination revealed a telling constellation of cranial and peripheral signs. The cranial signs like ocular and facial signs. She exhibited mild bilateral ptosis, drooping of eyelids, subtle extraocular muscle weakness, and mild facial weakness. Distal focus. Her muscle weakness showed an early pronounced involvement of the distal muscle groups. Sensory mapping. Interestingly, she reported mild sensory abnormalities such as diminished vibration sense in her toes. Electrodiagnostic study and a laboratory evaluation. To investigate the root cause of her progressive weakness, the clinical team initiated targeted laboratory and electrodiagnostic study. Serum creatinine kinase. Elena's blood workup revealed a completely normal serum creatinine kinase concentration, which is highly characteristic of this group of pathologies. Electromyography provided the clear evidence of severe muscle pathology. It demonstrated marked muscle membrane instability, displayed prominent fibrillation potential, positive sharp waves, and complex repetitive discharges. On occasion, the tracking even picked up subtle myotonic discharges. To definitely differentiate her condition from other congenital myopathies, neurologist performed a muscle biopsy of her distal lower limb. The histopathological analysis revealed the distinct structural anomalies. Routine HND and trichome staining, the tissue showed marked variability in the fiber size with a prominent population of abnormal small muscle fibers. Crucially, the center of the many of these fibers contained a large plump nucleus. While this arrangement closely resembled the early embryonic myotube stage of the muscle development, further structural evaluation confirmed they were true adult fibers. Longitudinal sectioning, when weaving along its length, it affected fibers demonstrated a long clear central area with internal nuclei spaced out at regional intervals. This stain oxidative enzyme reaction stain revealed a darkly staining central spotlight in the middle of the many muscle fibers. Almost all the fibers exhibited a distinct pale staining area running directly through the center. While this superficially mimicked a central core, the pathologist noted that a true central cores are typically invisible on ATPase staining, confirming a true internal nuclear architecture. The biopsy confirmed a clear type 1 muscle fiber predominance along with selective type 1 fiber atrophy, that is hypertrophy. Specialized immunohistochemical staining also detected the presence of vimentin and desmin, two fetal cytoskeletal protein structure, two fetal cytoskeletal protein abnormally retained in this older adult muscle structure. Based on the definitive presence of internal nuclei within the muscle fibers, Elena was officially diagnosed centronuclear myopathy. To determine the exact genetic mechanism driving her autosomal dominant centronuclear myopathy, Elena underwent targeted gene sequencing. The result identified a pathogenic mutation in the DNM2 gene located on chromosome 19p13, which encoded the protein dynamin 2. The identification of the DNM2 mutation provided an important moment for the clinical team. The mutation in this exact gene are also known to cause Charcot-Marie-Tooth disease type 2b. This shared genetic etiology perfectly explained Enila's atypical overlapping clinical features, specifically her early distal muscle weakness and her mild sensory abnormalities. It also safely ruled out the severe, often fatal X-linked infantile form associated with MTM1 gene mutation. Because there is no targeted cure or corrective genetic therapy available for centronuclear myopathy, Elena's medical team transitioned her care to comprehensive general supportive management plan. Orthopedic and physical therapy. Elena was fitted with specialized orthotic inserts to support her equinovarus foot deformities, stabilizing her gait and protecting her ankles from the chronic injury. Dedicated physical therapy sessions were targeted at preserving the strength in her moderately weak limbs. While her autosomal dominant form is significantly milder than the infantile variety, her care team established baseline respiratory function monitoring to ensure long term pulmonary safety.